honor of serving as chair of this committee. I'll go ahead and call the meeting to order. Go ahead to the next slide, so. I'd like to start by asking the members of the committee to introduce themselves. Maybe I'll start with you, Miko, and then we can go around to the left.
Sure, Miko Lincoln, Community Representative.
Rich LeClaire with the Department of Behavioral Health, Developmental Disabilities and Hospitals.
I'm Julie Hamill. I'm the State Court Administrator, and I serve as the Chief Justice in LA County.
Jake Bazillion, I serve as the Senate President's designee. I represent Senate District 1 in the Senate, which is here. So, welcome.
My name's Mark Donnelly. I'm the Chief of the City of Newport's Fire Department. I represent Newport County.
Rachel Farrar, I'm the Human Services Director for the City of Providence, and I represent the Mayor.
Patricia Rezendi, Chief of Staff for the City of East Providence, and I represent Bristol County.
Katie Hansen, Director of Adult General Outpatient Services at Thrive Behavioral Health, and I'm an expert on the committee.
I'm Peter Nerona. I'm the Attorney General.
Thank you for joining us. I'll now move to the UHHS staff. Kathy?
I'm Kathy Schultz. I'm the Director of the Governor's Overdose Task Force and also work with the overdose team. And I'll hand it over to our newest member of our team. So,
hi, my name is Selma Masuti, the Interdepartment Overdose Coordinator.
Tamara Berman, the OHHS Program Evaluator.
Christina Schultz, Lead Analyst for the Governor's Overdose Task Force.
Michelle Goncalves, the Finance Manager for Opioid Funding at OHHS.
All right, thank you all. We have two more members joining, but let's go to the agenda and then I'll ask them to introduce themselves once they're settled. If you go to the next slide, so we have a very busy agenda today. We are going to start with budget and procurement updates from Kathy Schultz. We thought we'd start each meeting with updates on the budget and any new procurements that have happened since our last meeting. We'll then hear from Ben Hallowell from RIDO, who will review the 2024 overdose fatality data, which is now finalized. And then we'll spend most of the time this afternoon hearing from three agencies who are responsible for managing many, if not all, of the contracts that are supported by the opioid settlement. And I'll introduce those staff who will be presenting today at that point in the agenda. We'll then move on to public comment and then adjourn for this afternoon. So before we approve the minutes, I just wanted to give Phil and Alex a chance to introduce themselves.
Good afternoon, Phil Chan from the Rhode Island Department of Health.
Hi, everyone. Alex McAdoo from the Brown School of Public Health.
All right. Thank you. So let's move to the next slide. As a first order of business, can I get a motion to approve the minutes from our May meeting?
Motion to approve May meeting minutes.
Second.
And we have a second. All in favor?
Aye.
Any noes? Any abstain? Motion carries. Thank you all. And the minutes are in your meeting packets if you'd like to refer to them later. All right. Before I hand it over to Kathy, I wanted to take a moment to highlight a new resource that we've made available on the UHHS opioid settlement website. We heard during the public comment last month that there was a need or a desire for more opportunities for members of the public to share information with the committee. So we've gone ahead and created a forum that is available on the UHHS OSAC website. Thank you, Tamara, for creating this form that any members of the public can use to ask us questions, to share information with the committee, to give more resources, and anything that they would like. And UHH staff will review those responses every 2 weeks, and then I will synthesize what we receive for all of you at each meeting. So just another opportunity to touch base with the committee outside of this public meeting setting. And then also, I wanted to let folks know that I'd like to move towards 2 public comment periods, also based on the feedback that we received at last month's meeting. We'll have a public comment period more at the beginning of the meeting, in addition to a public comment period at the end of the meeting. We're going to start that in July just because we have a lot of information to get through today. So that will start in July, but I'll make sure to keep track of time this afternoon to leave a good amount of time for public comment. Tamara, is there anything else you wanted to highlight with the form? It's now live, correct?
Yeah. It's, right there, there's a call out box towards the top of the page, so anyone can submit information, and then we also have the email addressed there. So we check it regularly and hopefully we can be able to compile and share everything with all of you.
Thank you.
Okay. Hi, Dennis. Would you like to introduce yourself? I'll put you on the spot.
Yes, that's okay. Dennis Baylor, expert representative.
Thank you. All right, so I'd like to turn it over now to Kathy, who will provide an update on some budget and procurement information since last month's meeting. Go ahead, Kathy.
Thank you. Thank you, everybody. I think I know everybody here. I also want to welcome our newest member of the committee as well, Senator. Thank you for joining us. I'm just going to give a quick status update, basically on some of the procurements, but let's start off if you want to move to the next slide. With just an overview of the funding over the last couple of years. So this is the total for state fiscal year 23 through state fiscal year 25. And as you can see, these are the allocations. We broke that down by each agency. These are the main agencies, and you're going to hear more on some of the programmatic updates. These are the main agencies where most of the funding is going to procure out into the community, to our community-based organizations. So as you can see here, EOHHS, we put estimate because we just, I have our budget person, our budget finance person who is very confident in making sure that we're always on point to the penny. So that's why we have the word estimate next to that, because we're rounding them off. So we had 24 million through EOHHS, and of that 12 million has been spent as of May 2025. I want to also remind everybody that this is at the end of fiscal year. So we do anticipate that there's going to be a lot more invoices coming in, because our fiscal folks across our agencies are reminding everybody, hurry up program folks, we need those invoices in before fiscal close. And that would be across all of these agencies. And then of that, there's estimated encumbered or obligated for FY 25 and 26 is about $23 million. And then we can move on to RIDO, the Department of Health, $8 million, $5 million of that has been spent, and approximately all of that is encumbered. And then BHDDH, we have $16 million, $5 million of that has been spent, and $9.2 million has been encumbered or obligated, which means, let me give you a little explanation of that, which means that there's an RFP, so this money is obligated to an RFP that's already out. It could also be that it's in contract already. It could also be that it's in planning and it's just in the process of becoming an RFP. So these are estimates, and by the end of fiscal close in the beginning of next fiscal year, we anticipate those numbers to go up as well. And you are going to hear more from our agencies, so they can explain a little bit better on that. Any questions on this?
One quick question, just for the EOHHS line. There's 23 million encumbered and 12 million spent and 24 million allocated. I think I would expect the 12 and 23 to add up to 24.
The 12 and 23. Well, I just put it all together. That's the same thing as like RIDO. It's 8 and 8. You see it?
Okay.
So it means that spent is separate, and then the encumbered or obligated is just what is already in an RFP or has planning or is like in the process of being procured.
Got it.
Okay. Also, in addition to that, you do have a more detailed report for the committee members. If you want to take a look at that after this meeting, we did try to get that completed and sent out to you all before the meeting. Unfortunately, there was a lot of information in there, and we wanted to make sure that we had as much as possible for you all, and then we can probably revisit that in July if you have any questions.
Can I ask a question?
Sure.
What is the source of all this funding? Is some of it the opioid settlement, all of it, or a mix?
All of it is opioid settlement funding.
Okay. And why, if RIDO is a part of EOHHS, why break it out in that way? You know what I mean?
So
RIDO is a sub-agency of EOHHS. So why have a separate line item?
They are their own agency. Does the Department of Health want to answer that? And also BHDDH is also their own agency. The funding comes through EOHHS with Michelle and our team. And then what we do is we meet with all of the agencies, and then the agencies, we kind of divvy it up based on the consensus vote and then what is approved by the secretary.
I see. So the $24 million in the line item for EOHHS is separate and apart
Yes.
from what goes to RIDO?
It's specifically for EOHHS. We have our contracts as well.
I understand.
And
Okay, thank you.
partnerships. We do have a comment. The money is encumbered through the state budget process and as such needs to be allocated by agency. That actually, the Assistant Secretary is in the chat, so.
Great.
Thank you, Anna.
Could you go to the next slide, Kathy?
Yeah. Okay, so there are a lot of words here. I am going to skim through it. And again, you will have a presentation from the agencies. And these are some of the planning and updates for state fiscal year 2025 and 2026. And what we really did was I looked back at what we were planning for last year, and I kind of gave us updates so that we can see where we are now as far as some of the plans that we were anticipating last year. So EOH for municipal funds, we are happy to report that we have an open municipal fund opportunity on our EOHHS page. And what we are doing is we are offering funding with two options, one of which option one is mandatory, and that is to basically work with EOHHS to try to help with coordination of data as well as partnerships. So we just want to make sure that we're providing additional support to our municipalities for the 20% of opioid settlement funds that they have, because we know we've heard that from you all in the committee about municipalities. So this is an incentive opportunity. We also have option two, which allows an expansion of some of the programs that are happening. And I'm happy to report that we're actually in partnership as of right now with the City of Providence to do just that. And there's actually a space in the RIPTA hub that they are coordinating the community partners that are able to use that space to have some more privacy with clients. We also are in our third round of partnership with Rhode Island Foundation. And those applications have closed on June 6th, and we're in the process of evaluating them now. And they are focused on first responder trauma supports, emerging issues, recovery supports for individuals and families.
Can I ask a question about that line? Who's making the selection as to where those monies would go? It's gone to the Rhode Island Foundation, but who decides among the applicants who receives the money?
We have representation from each of our state agencies, the Department of Health, BHDH, EOHHS, as well as we put together an entire evaluation committee, and the Rhode Island Foundation also joins us. We are actually analyzing the reports and doing an evaluation on each of the reports.
So pushing money out through the Rhode Island Foundation has not been controversial. The opioid funds that we recovered, that my office recovered, and pushing them out through the Rhode Island Foundation has not raised any issues or concerns. Is that fair to say?
It is fair to say. We're in a memorandum of understanding with the Rhode Island Foundation.
Terrific. Great. Thank you.
Can I ask a follow-up to that, just for my own edification? Do we vote on any of the, does this body vote on any of the individual recipients?
No.
Okay, good.
No, not at all. No, we have to follow the state budget process.
Okay, all right, fair enough.
The MOU with the Rhode Island Foundation is a partnership with the EOHHS, and we also include our state agencies as representation on the evaluation.
And a lot of that, Senator, was set up through the court consent decree that we filed with the court. And that guides how the money must be spent. So if the money is not spent in the way that it should, then my office can go back to court to ensure that it is spent in the right way. We haven't had any concerns about that, but it was deliberately set up that way in the court order, the consent decree that we obtained from the court when we settled all of those cases, including the one that we brought here in Rhode Island.
All right, thank you.
You're welcome.
Thank you, Kathy.
No problem. Okay, moving on to the next Community Overdose Code project. Some of you who have been doing this work for quite some time would recall that we have had what's called the CODE project. It's the Community Overdose Engagement. That's what it stands for. And we are actually in the process of finalizing our evaluation and procurements in partnership with the Department of Health. We also included BHDDH as part of that evaluation process. And those funds are going to go out to specifically to local community efforts through the health equity zone. So we're really excited for this. We've done this in the past and we've seen a lot of success in this type of engagement. And we heard that also from the recommendations from the community as well as here in the Opioid Settlement Committee. And finally, treatment and recovery.
Is there any concern about the HES's capacity now that they might not be receiving the state funding that they typically do?
I can't really answer that question, but I think that you could probably reach out to maybe the Department of Health who oversees the health equity zones. I'm sure that they're fine. And we did make sure that in the funding opportunity that they also are able to have the ability to have some capacity within their health equity zones.
Thanks.
Okay. And finally, treatment and recovery. You're going to hear from BHDDH today, and I think that they're going to give you a lot more information about this. There was so much information to give on some of the updates that we actually had to bullet them and make them a little bit smaller. But Linda Mahoney and Candace Rogers are both going to be presenting from BHDDH on some of the work that's happening. But we are excited to say that recovery expansion of recovery housing continues. There is an RFP that is live. Right now, BHDDH enhancements on substance use disorder treatment, residential treatment. We have youth. We also have stimulant use and adult male treatment RFPs, or they're in the process of evaluation. And Linda Mahoney can share more about that status when she presents. And EOHHS is in the process of offering funding opportunities for oral health. That is in the procurement process as well. And then EOHHS and BHDDH continue to work together to work with our community-based organizations to provide workforce supports to our peer organizations. So those are just some of the updates. And again, there is a much more comprehensive list of the things that are happening, which I want to remind you all, there's probably over 100 contracts and approximately 50-something initiatives right now. So there's a lot of work happening, and we are very, very thankful for the opioid settlement funds.
Any other questions for Kathy before we move on? Thank you so much, Kathy. All right, in a moment, I'm going to invite Dr. Ben Hallowell from the Health Department to come up. We thought it would be helpful to give you a brief summary of where the state stands with fatal 2024 overdose data. The intent is not to provide a deep dive on the data this afternoon due to time limits. Ben did present this information in depth at the recent task force meeting, and those slides we're happy to circulate. There's also a recording available on preventoverdoseri.org. So it's my pleasure to introduce Dr. Ben Hallowell. He's a good colleague and friend of mine. He's also the team lead of the Substance Use Epidemiology Program at the Rhode Island Department of Health. So he'll present on the 2024 data, and then we'll be joined by two other colleagues. I'll introduce them in a moment once we get to that part of the presentation. Go ahead, Ben.
Sounds good. Thank you, Dr. Marshall. You can do the next slide, so. So in 2022, Rhode Island had the highest number of fatal overdoses that we've ever recorded, of 436. And when that was finalized in the summer of 2023, the Governor's Task Force met and they picked a goal to try to reduce the number of overdose fatalities to the level we saw in 2019, which would be a 30% reduction, which would give us 305 deaths by 2030. And this was set by the Healthy People 2030, which is a CDC population health guide that sets goals for things that states should try to achieve. So on the left, we have the counts of what we've had for fatal overdoses in Rhode Island from 2016 to 2024. And on the right is our benchmark goals. If we made continual small improvements every year until 2030, those are the targets we would be trying to hit. So we can see so far from 2022 to 2024, we've had a 25% decrease, which is awesome towards our goal of 30%. The follow-up question I get is how does this compare nationally? Nationally, during the same time period, it's a 27% decrease. So I would say very similar to what we're seeing in the United States overall. Next slide, please. So this was put together by Chris Schultz, just going over the 4 main demographic trends that we've seen over the last few years. In the top left-hand corner, it shows the age group of people who died of an overdose in Rhode Island. The one thing I wanted to highlight in the far in the far right, the 36% is the proportion of overdoses in 2024 that occurred among people who were 55 plus. And this year, individuals 55 to 64 had the highest proportion of fatal overdoses in Rhode Island. And they're the only age group that went up from 2023 to 2024. On the right, we have the percentage of individuals broken down by sex. And from 2018 to present, basically every year, about 70% of people who die of a fatal overdose are men. And then on the bottom, we have the rate of fatal overdose by race and ethnicity for non-Hispanic white, non-Hispanic black, and Hispanic or Latino. Encouragingly, from 2022 to 2024, you can see that they're decreasing across all demographic groups. And notably, non-Hispanic black still has the highest rate of fatal overdose in Rhode Island. Any questions on that?
Doctor, do you, the statistics are fascinating and the presentation was great. Do you have any sense, or does anyone study the whys? Like, why are we down? How do we explain that we've gone down over the last 2 years when it had sort of been a constant? If you go back to the previous slide, sort of have been incrementally going higher. Have we been able to attribute that to anything?
I think there's some work being done for evaluation. I think it's tough to, I don't think there's a single smoking gun. There's hundreds of organizations that have been working on it for many years. And I think it's the cumulative effort of a lot of things over time, but I know that they're funding some evaluation things that hopefully will shed some light on it going forward.
And I think, just to add to that, there is a more comprehensive, there is access to it in the archived presentation on Prevent Overdose RI that gave much more information about the different types of trends that are happening. And I think it's also really important to remember that nationally, all of the overdose rates were actually going up in part due to COVID-19.
Right.
Social isolation, what I anecdotally believe that social isolation really played a huge part in it, especially being a person in recovery who was socially isolated.
Right. Well, if they went up consistently across the country and are now, Doctor, to your point, coming down consistently across the country, isn't one common denominator that all of the opioid cases settled 2 years ago? I mean, has anyone drawn that connection yet?
Not that I'm aware of yet. I think it's tough because Rhode Island's also one of the first states to get the money out. And I think many people that got it, to my knowledge, are just starting to get their projects funded. So there'll probably be a larger impact down the road.
Have we increased the number of beds, inpatient treatment beds with this money? Are we going to get there? If we are, then we're getting there? Great. Because, you know, it's, what I'm looking for is the whys. I mean, it's all well and good to understand things are going down, and that's great. But it's hard to build policy around data, right? You need to understand the whys so that you can double down on the whys, drive the number even farther down.
And I think that when Ben moves on to the next part of the presentation for the surveillance systems and some of the other whys and the data that they're looking at, and then our programmatic updates, you're going to get some of those answers.
Great. Thank you.
I'm sorry, I just want to see if I could add something to that. You know, I've been working at Weber Renew for a lot of years. And I think that it's the Narcan distribution has had a lot to do with the reduction of deaths, not only in our state, but nationwide. I think Narcan has played a really, really big role in preventing overdose deaths.
And it's more available now?
Definitely so.
Yeah, I think that's a great point, Dennis. And one thing to note that we don't talk about very much because it wasn't a financial part of the settlement, but the Teva Pharmaceutical settlement did provide 50,000 kits of naloxone to the state. So that I like to highlight because it's not in the dollars and cents, but I agree with you as providing that financial, sustainable access to naloxone.
Yeah, then from the community organizations and the state itself, it's just been really, we've really saturated those
I think Denver
hotspots.
agreed to supply the state with naloxone for a decade, I think.
I think so. Yeah.
Yep, a question on the previous slide, you indicated that blip in the overdose deaths, say ages 45 to 55. I'm not sure for the last year. Do you know how that compares nationally? Is it something just isolated to Rhode Island, New England, or is that more of a national issue, or do you have the answer?
I think many states are still finalizing, but preliminary data, I think it is potentially a national trend that we're seeing. But we should know more in the next month or so as the other New England states all close out their data for the year.
Thank you.
And one point I just want to make about the Narcan distribution to build on Dennis's, Dr. Marshall's lab has done some research on the number of community reversals we've seen, and it's over 4,000 overdoses are reversed in the community that don't receive medical attention. So without the naloxone distribution, I think it would easily be over 4,000 deaths a year if we didn't have lay people able to respond in the field.
Yeah, so there's a why.
Alex, one more question, then we'll move on.
Oh, yeah, not a question, just a quick statement or a quick observation that I just wanted to flag to folks that it's really heartening that state data are also emulating or reflecting national data as well, and that we're seeing also a reduction among young people, which is super exciting and something we should be heartened by.
So hopefully these data are helpful as we start to make recommendations for fiscal year 2027. And again, a deeper dive on the data is available and we can distribute it to all of you. I wanted now to move us to the second part of the presentation today, where you'll hear from 3 of the state agencies that are responsible for managing the opioid settlement funds. As Kathy mentioned, there are more than 100 contracts and 50 initiatives funded using settlement dollars. So we didn't want to summarize everything today. That information is available to you in a more detailed report. But we asked the agencies to highlight some of the key programs that either they're managing directly or that they contract to through community-based organizations. So that's the plan for most this afternoon. We're going to start with the Rhode Island Department of Health. So Ben's going to lead this part of the presentation as well. He'll also be joined by 2 other staff members from RIDO who are joining remotely, I think. Is that right, Ben? They're on vacation, so they've kindly offered to join us remotely, and that is Jen Kojal, who's the team lead of the Drug Overdose Prevention Program at RIDO, and also Margot Katz, who's chief of the Perinatal Substance Use Task Force Program and state co-chair of the Perinatal Substance Use Task Force. So Ben, take it away.
Sure, thank you. So today I'll be talking a little bit, in the budget that gets voted on, there's a percentage of the settlement and stewardship data that funds that goes to data. And this is basically how some of that data percentage is used at RIDO. And I manage the epidemiology portion of this, but I'll also be talking on behalf of the lab, which does all the toxicology testing in the medical examiner's office. You could do the next slide. So before I get started, I just want to highlight that there's a number of different programs at RIDO that all do substance-related work or try to prevent substance use-related harms. In this top center one here is my program, Substance Use Epidemiology, and I'll also be talking on behalf of the lab and medical examiner. Jen later will be talking on drug overdose prevention, and Margot Katz leads the perinatal substance use program, but you can see there's many other programs at RIDO that also do substance use related work. Next slide. So the goal of the substance use epi program, the lab, and the medical examiner is just basically to generate, manage, and disseminate data on substance use and prevent substance use related harms in Rhode Island, and then use that data to inform prevention work. And on the left side of this slide, I know it's kind of busy, is what we do on our day-to-day operations. And on the right side is projects that have been specifically funded using either stewardship or settlement funds. So on the left side, just a very high overview of what we do is basically trying to serve as the statewide source for all data on fatal and non-fatal overdoses, the toxicology for both of those, what substances people are using when they overdose. We monitor all the controlled substance prescribing through the PDMP, so all opioids, buprenorphine, benzodiazepines. We track all naloxone and harm reduction distribution in the state and monitoring where it's going and who it's going to. And I guess that's the big ones. The other thing we also do is monitor non-fatal overdoses in real time. So every day we update our hub site with the number of non-fatal overdoses that have occurred in the last 7 days and the last 6 months to look for spikes in overdose activity. And we then send out spike alerts for any region with abnormally high count, and then work with the prevention team and community partners to respond to that. We also provide data and technical assistance to a number of governmental and community partners, including a lot of settlement or stewardship funded projects, to make sure that their interventions are based in data and then provide the data that they need to evaluate those projects. And then finally, we provide all this data on our website, which is also synced to Prevent Overdose RI. And so those, both of those websites get updated with data from our program. In terms of projects that have been specifically funded by OSAC, I think the question I got last time I was here was, many of these programs existed before the settlement happened, so why exactly do you need settlement or stewardship funds to continue these? While we work at the health department and we're state employees, we're 100% grant funded, primarily by the CDC and NIH. And sometimes cool projects come along that we can't do with either of those grants. And this gives us some flexibility, a lot of times to do one-off projects to serve communities. And so some of those are to track all the statewide naloxone and harm reduction distribution. These funds operate the overdose fatality review team for Rhode Island. I'm going to go into these next two in the next two slides, but develop an overdose heat map dashboard and develop the new integrated surveillance system. Provide ongoing support to the Office of the State Medical Examiner to help reduce their delay in death reporting and case backlog. It was about 9 months behind, now it's about 6 months behind. Allowed the lab to purchase biosurveillance laboratory supplies to enhance drug testing, provide ongoing data trends to the task force and work groups, and ongoing data to partners that are funded by RIDO, the settlement, or the stewardship funds. Next slide. So this is one of the two things that I wanted to highlight that the stewardship funds help support, and this is the new integrated surveillance system. So basically what the system does is takes all non-fatal overdoses that happen in Rhode Island. We get data from emergency medical services and the ED, and we feed it into one source. We then divide the state up into these 11 regions. And then in the center column here, we have the number of overdoses that happen in the last 7 days. And then this column looks at the last 6 months. And so by dividing the state into these various regions, we then have thresholds that would be considered unusually high activity, which signifies that we need an immediate response by the health department to intervene, and it's outside of our normal activity. So for example, Johnson and North Providence, on the day I took the screenshot on June 4th, had an overdose spike because they had 4 or more overdoses in a 7-day period. So we issued a spike alert. We worked with prevention and disseminated this information to our community partners. They didn't have any continued activity after the spike alert and intervention, so we didn't need to do anything else. But had that continued, we have escalating responses to help address that. As part of that, we also make heat maps that we put on our website and share with our partners, and we disseminate and recreate those every 4 weeks and give those to our community outreach partners to help them know where to go. We share this every morning with BHCDH with Linda at 9:30 every Wednesday. We share with community outreach workers every Wednesday at 1, and the state partners every Wednesday at 1:30 to make sure everyone's using the best data available. And that's a QR code that can take you to the site if you're interested in seeing what the numbers are today. Oh, and I didn't cover this last column. This last column looks at the number of non-fatal overdoses that happen in the 6 months in each of these communities divided by the population. And our goal is to try to identify communities that have a disproportionate burden of overdoses. And in the absence of a spike, we try to focus on communities that have higher than expected numbers of non-fatal overdoses to try to make it equitable across the state in terms of burden. Next slide. I just have two more. So this is one that I think was funded by the settlement in 2023, but it's taken us over 2 years to actually get it off the ground. This is a heat map dashboard, which we're pretty excited about. The plan is for this to launch this fall. It will be behind a login wall and not available to the general public, but allow our community partners to log in and make custom heat maps. As an example, if a group was interested in providing services to individuals at risk of an overdose 55 to 65, they could pick that filter and make a custom heat map for the town that they're interested in for where individuals that age group are overdosing in their community, and then target their interventions for those areas. So we hope that it will be really helpful. The plan for this will be to get updated every day with new data and then available to community partners. So this will have both fatal and non-fatal overdoses. Next slide. And just a reminder that these are the various data systems that our team manages, and then these are all synced to Prevent Overdose RI. And that's all I have.
So I think we'll move to the presentation from Jen now. Jen, are you on the Zoom?
Hi, yes, hear me?
Hi, Jen. Go ahead.
Hi,
I
can
think-
you all hear?
Yeah, we can hear you.
Okay, I'm on my phone. My computer just lost connection, but I know Sarah Edwards is in the room if I do lose connection, but I'm gonna go ahead and jump in. So I will be presenting on the work of our funded harm reduction organizations today. So those include AIDS Care Ocean State, Community Care Alliance, and Project Weber Renew. Those three organizations right now serve the entire state of Rhode Island. The data that you're going to see today also includes Parent Support Network, who was funded and ended their contract last fall. So just to remind everyone, harm reduction is an evidence-based public health approach grounded in the principle of meeting people where they are. So that means both geographically in terms of where folks are located, and then also where they are in their substance use experience. So some of the major, this is very broad, some of the major activities that our organizations do each week is they participate in a meeting which is convened by RIDO, Sarah Edwards. That meeting is an opportunity for the peers who are, on the ground doing the work to connect and collaborate with one another, kind of like troubleshoot in real time. Each week we look at the most current data, and that data informs their outreach efforts for the week. They also, a big priority for all three organizations is to staff peers with lived experience, which really helps with the success of the work. And then they're doing mobile outreach every single week, as I mentioned, going out to high-risk areas. Let me see. So very broadly, again, the program contract level goals are to provide supplies and education to clients at risk, also family and friends, and then to connect at-risk individuals to treatment, recovery, and housing resources when and if ready. And part of their contracts are, they are required to use data to inform their efforts. So they're doing a lot of effort outreach to disproportionately impacted groups. In terms of funding, we receive over $3 million a year for this work. Right now, we've spent down about $1.5 million in FY20 or in FY25. And this work is supported by braided funding. So we not only get funding from the settlement and stewardship, but also from a CDC federal grant. And then we also have a few other buckets of very small state dollars. Next slide, please, Carol. Carol. So again, reduction is grounded in the principle of providing as many low to no barrier access points as possible. So our organizations are very adept at this. They know the communities that they serve quite well. They currently make services available through drop-in centers. Right now we fund 3 drop-in centers in high burden areas, one in Providence, one in Woonsocket, and one in Pawtucket. They also have vending machines in high burden areas, high pedestrian traffic areas. They do the mobile outreach work, as I mentioned. They do a really great job of collaborating with the businesses and community-based organizations in the communities they serve to connect through those door-to-door canvassing. And then they also provide home delivered services for those who need that. Next slide, please. So now for some data. So you can see here, let me zoom in. You can see here the yellow bars in the top graph, those represent any encounter, and then the blue represents unique clients. So you can see the number of connection points that they're making has really increased since 2022 into 2023 moving forward when we started to receive the additional settlement dollars. So that's been great. You can see what a great job our organizations are doing of connecting with folks. Just to summarize, because I know this is very tiny, In 2024 alone, I think we had over 25,000 encounters, and that's with about 7,500 unique individuals. So this is just great to see because every single encounter that our community-based organizations have with a person is a chance to build trust and develop a relationship, provide resources, and with the hope that that relationship will continue to evolve and more services can be provided as when and if folks are ready. And then the next graph below there represents the data by race and ethnicity. So the yellow line represents the non-Hispanic Black population. The grayish line is non-Hispanic, it is a Hispanic population. So you can see those rates are a little bit higher, which we are very happy to see because these, we know, as we just saw from Dr. Hallowell, that those populations are disproportionately impacted. So again, our organizations are doing an excellent job. I think part of this is they prioritize hiring and retaining staff who are representative of the populations that they serve. So I think that's been really effective in helping them have success here.
I'd just like to jump in. I'd just like to jump in with a question, please. So it seems like the encounters have gone up, and you mentioned staffing. Has overall staffing gone up at the agencies?
Yes, it has, mostly because our funding has increased, so we've been able to provide more support and resources to the organizations to increase their staffing.
Okay, thank you.
Yep.
Don't see any. Go ahead, Jen, with the next slide.
So this is my last slide. So this, I just wanted to highlight here, one of our most important goals really is to improve the overall health and wellness of our clients. That is one of the main principles of harm reduction. The populations that our organizations serve are the most vulnerable in Rhode Island. You can see here, so for example, the unhoused population, unfortunately that number has increased between 2021 and 2024. It's gone from 58% to 68%. Given this and other factors, basic needs is our most popular supply requested. So this can be anything from a bottle of water, food, clothes, soap, shampoo, blankets, transportation support. Last year, 74% of clients received basic need supplies. And another important part of the work is screening and prevention for things like HIV, hepatitis B and C, STDs, and congenital syphilis. So the good news is new HIV diagnoses have remained at an all-time low, fewer than 5 cases per year. And additionally, there were 0 congenital syphilis cases among people who use drugs in 2024. So unless there are any other questions, before I turn it over to Margot, I just want to say thank you to the organizations, the staff at the organizations that are out there doing this work every single day. It's very challenging work. They're super committed, and none of this could happen without them. So if there are no other questions, I'll turn it over to Margot.
Thanks so much, Jen. Margot, go ahead. I think you've just got one slide, and then we'll stop for a few questions if we have some time.
Great, thank you. I just want to make sure everybody can hear me because I am also on my phone.
We can hear you great, Margot. Thanks so much.
Great, thank you. So Margot Katz here. I'm the chief of the Perinatal Substance Use Program and the state chair of the Perinatal Substance Use Task Force. We used to be called Substance Exposed Newborns, and we decided to change our name because our interventions are really focused on prenatal and postnatal interventions within the prenatal and postnatal periods. So I wanted to highlight 2 projects that we've been developing in the past few years with this funding. The first is perinatal peer services. We have certified peer recovery specialists who are also community health workers who have lived experience pregnant and parenting with substance use conditions and have special training to serve this population. So their job is to receive referrals from a variety of sources and to try to engage the client, hopefully prenatally, so that there's more time to right the ship before delivery and keep the family together. and to get mom's health on track, et cetera, et cetera. They also do care coordination with Women's Health Street Outreach, which I will highlight in a moment. Family visiting, family visitors. There are bidirectional referrals with family visiting programs. They work with DCYF when the family is involved to, again, help the family stay together. They work with family court, safe and secure baby court, and I think it's called, I don't remember the other court, forgive me. They work with the Department of Corrections, and they work with treatment and prenatal providers. From 2022, and this is the end of 2022 when we started, to present, we've had 182 referrals. 97% of them were outreach, and 74% of them were engaged with services. Peer coaches, perinatal peer coaches are available 24/7. This is the phone number. We also have a resource website, recoveryhopeformomsri.org. And it's a really wonderful program. It's a safe, non-judgmental space for pregnant people who are using substances to receive help and support, because it is a time when families are incredibly feel vulnerable, and we want to give them a safe place to basically engage with supports and services, including treatment, recovery, whatever they need, and to link them to care. So are there any questions about perinatal peer services before I move to street outreach? No, great, okay. Harm reduction, women's health street outreach. So all the information that Jen just gave you about street outreach, we have a little corner of this. We really wanted to focus on this population, women of childbearing age and pregnant people, to just make sure that we can support their health and well-being, again, during particularly vulnerable times. So basically, we're working with Project Weber Renew and AIDS Care Ocean State, their street outreach teams that already are in existence, and we're basically giving them funding for supplies, and we're giving them educational material to give to their clients that will hopefully encourage them to link to care, whatever kind of care they need, and to also identify safe places for them to seek prenatal care if that's what they need. So they do this, Project Weber and ACOS, they do this through drop-in centers, mobile outreach, vending machines, and home delivery. Some of the supplies include early pregnancy tests, hygiene products, emergency contraceptives, and referral resource cards that guide them to prenatal care or the perinatal peer services on the other side of the slide. Also, referrals to perinatal peer services, treatment, recovery support, and prenatal care. And to date, they have distributed over 100 reproductive health kits and have made more than 30 prenatal referrals. And in the middle are some of our messaging material. We have had a messaging campaign, Pregnant Using We Can Help, for the perinatal peer services. That's been out there all over Rhode Island for a number of years. And then there's our Healthy Beginning campaign, which basically speaks to the fact that every woman wants a healthy pregnancy and a healthy baby. Are there any questions?
Actually, this would be a great time for any questions from our RIDO representatives. We've got about 5 minutes before moving on to BHDDH. We have a request, committee members, if you could just state your name and your role for the folks on Zoom, that would be helpful. I think I saw one. Dennis, go ahead.
Dennis Baylor from Weber Renew. Hi, Margot, how are you?
Hey, Dennis.
Because I love all the work that you're doing at the prenatal substance use task force or group. But I know that one of the challenging pieces is treatment for are women who are pregnant, trying to get into recovery. How goes that battle? Are we making any headway in getting more beds available for them?
You must be talking about the inpatient treatment for pregnant people. Is that what you're talking about?
Correct.
Yeah, yeah. So, there is a need for women for pregnant people who need a level of care, inpatient level of care, to receive treatment while they're pregnant. And right now, that is not available in Rhode Island. And so this is I'll use the word battle that has been being waged by people far above my pay grade to get this really important and necessary support for this population. There is a very small window of opportunity when somebody is battling substance use and they're pregnant. And it's important to be able to respond to that window of opportunity when they're ready, when the need is inpatient care. So this is a very, very important thing that Rhode Island does not offer. And I wish I could share with you the details of the work that is being done to make this happen. I know that Dr. Whiteman spoke about this at the Governor's Overdose Task Force. I think it was earlier this year or at the end of last year. But it's still a great need because every pregnant person deserves a chance to get the level of care that they need when they're using substances and are pregnant. So that's all I can say about that, unfortunately.
Thank you for highlighting that challenge, and I hope that the state steps up and we can provide those services.
Yeah, sure.
Thank you both. We have time for one more question for the RIDO representatives. Okay, thank you all. Let's move on to BHDDH. It's a pleasure to introduce two colleagues from BHDDH, Candace Rogers, who is the Unit Administrator for Prevention and Recovery Services in the Division of Behavioral Health and also the Co-Chair Recovery Work Group, and also Linda Mahoney, who's the State Opioid Treatment Authority and also the Co-Chair of the Treatment Work Group at BHDDH. They will be presenting today on two opioid settlement funded programs, RISAS, which is one of the key school-based prevention programs that the settlement is funding, and also work to expand treatment, specifically residential capacity in the state. So go ahead, you two. Would you like to come up here?
It's
or
whatever works best.
Yeah, come on up. For
Okay.
and I think they can hear you better if you're up here. Yeah. Go ahead, Candace.
All right. And so we can go ahead to the next slide. So I also represent on the state's National Prevention Network representative, and my unit is responsible for overseeing all prevention and recovery programming at BHDDH. Just for some perspective, at BHDDH, we manage about $45 to $50 million, depending on our discretionary grants that we have available that year. And that's more than 250 contracts related to substance use prevention, treatment, recovery services, and also mental health. So we cover the behavioral health continuum. We wanted to talk today about student assistance, in particular because you notice that not all of BHDDH's funds are encumbered. And I wanted to explain partly why, and it's because of the student assistance program. So student assistance is not new. It's been in Rhode Island since the late 1980s. The law went into effect in '86 that established the Rhode Island Student Assistance Program, and that was specifically in middle schools initially. And then it expanded into high schools just 2 years later. Current vendor, because we do put this out for bid, in fact, it'll be up for bid again in either 2027 or 2028, depending on one of our funding sources and whether we get an extension or not. But the current vendor is Coastline EAP. They have selected an evidence-based program called Project Success for implementation. So you'll see here that schools using coordinated community efforts to strengthen students. That's what it stands for. It is a multi-component intervention in which a student assistance counselor is embedded within a school. And some schools share a student assistance counselor if they are smaller in size. So for instance, someplace like Little Compton, in which the schools are a little bit smaller, they would share a counselor between middle and high school at times, just to make sure that there's enough capacity to go as far as it can. Every student assistance counselor does have a master's. They are providing direct services to the kids directly in that school. We also do use this as a workforce development program because you don't have to be licensed in order to work as a student assistance counselor. So it's a great way to get your hours for licensing if you're working with kids. So we see that quite often. The program itself has multiple components to it. So the first component is that there is a screening, brief intervention, and referral to treatment element for students that are getting sent to a student assistance counselor. They could be sent because they've been identified as having a parent using substances. It could be that they're just going through a transition and having a rough time. It could also be that they have been caught with something like vaping or alcohol on campus. Whatever it may be, they're sent to the student assistance counselor and they start building that relationship with the student. So usually by the third visit, they'll initiate screening. Brief intervention, a lot of times they'll use from the 7 challenges curriculum, brief challenges. And then the referral to treatment is not just referral to treatment, it's referral to whatever it is that they may need in the community. There are also, in addition to that, a parent engagement piece to this work that's happening. So a lot of times their student assistance counselors might come to parent-teacher night and be available in order to work with parents. You also will see individual and group counseling. There is a student group where basically the parents are using, they'll have a group of those students together. There is an individual element as well. And then as part of this curriculum, there is an 8-session universal prevention curriculum that's done in all of 1 middle school grade and 1 high school grade. We have, with funding that we've received, added tobacco and vaping prevention as the years have gone on. We've also most recently added with state targeted response, which is the predecessor to the state opioid response federal grant. We added opioid prevention modules. So that is implemented as part of this. If you can go to the next slide. We did a research study back in 2023. This was right around the time that COVID had been starting. We were taking a look at the student assistance work. And the easiest way for us to do that at the time was to compare schools that had student assistance to ones that didn't. And we looked at very similar demographics and areas in order to make sure that we had control groups that made sense. So with that study, and that study was done by Dr. Sam Rosenthal, so shout out to Brown because she does have affiliation at Brown School of Public Health. She's also with Johnson & Wales, just in case you want to find her, she's at one or the other. She did this research study that showed that there was statistically significant fewer depressive symptoms, a 20% lower suicide ideation, 35% lower past month use of cigarettes, 20% last month use of alcohol, so it went down, and then 28% past month of vaping and 27% lower past month use of cannabis for schools that had student assistance counselors versus those that didn't. So we knew the program was working, and with that came some significant investments. You'll also notice I did highlight that this is well aligned with the Governor's Overdose Task Force's plan, because we wanted to make sure that that alignment happened when we proposed this program for funding. If you go to the next slide, I'm trying to be very cognizant of time. I did want to highlight COVID, which I know we all want to put that behind us at this point, but that was a really big pivot point for our student assistance program. Specifically, around this time, we were funding about 35 schools in total for student assistance. So there were a lot more than 35 schools in the state, but we didn't really have the funding to do more. And then COVID hit. With COVID came supplements to the Substance Use Prevention Treatment Recovery Services, it's now a mouthful, block grant. And with those, we really wanted to focus on ramping up student assistance services because like Kathy said earlier, we were concerned about isolation and what the students were experiencing due to COVID. So we used that money to increase from 35 up to 75 schools. So that's kind of where we're at right now and where we've been able to sustain. And the reason is because of the settlement dollars. Because this money expired September 30th of 2025, it completely went away. And the student assistance portion spent down even prior to that. So it was really important to us that we had the money to sustain. It also was really interesting because this was one of our prevention programs that during the epidemic and with schools closing, we were able to continue. Student assistance counselors got very creative in terms of how they figured out how to reach students while not being on the same campus as them. So a lot of them held virtual classrooms that they were able to connect through the different schools because every school has their own platform and how they want to manage through the pandemic. So they were able to continue. The prevention education series also went virtual, so that universal prevention element was available to all. We also produced a lot more materials in order to make up for some of the in-person services and just made sure to be really cognizant that if somebody needed referrals, that they were able to get them. If you want to go ahead, that's where you see sort of the bump over the years of the number of student assistance counselors. It was because of the number of schools going significantly up. The next slide. So with that being said, at this point, what we've been doing is using the settlement to sustain and maintain, but whenever there are additional resources that Coastline has secured, we've used those dollars first so that this is the backup. That's why our encumbered number is somewhat low. So for instance, they have through some carryover funds, we're calling them carryover, it's not really carryover, but Kathy and I have worked this out. We have some additional resources to tap into in terms of if there's some sort of crisis and emergency. And I'm very glad we do, because this year might be the first year that we need to tap into some of those additional funds. So with RIDE experiencing some funding cuts, the school share portion that a lot of the municipalities are investing and putting in has been trouble for some of our usual schools that we work with. So we might have to chip in a little bit extra in order to support them and make sure that they can continue the services. So that's happening. I did also want to point out, we do a Rhode Island student survey every 2 years. The sample size for this is approximately 20,000. You do have to opt in to participate, but at this point, much more than half the state participates. The reason we really want to continue to invest in student assistance services is that the mental health indicators, of which are the precursor for substance use, are not looking particularly great. So it hasn't been since COVID. We've had some serious problems. We've also still seen an uptick. While all the other 30-day use of substances went down for kids, whether middle school or high school, there's been one change that is different, and that's cannabis use. Cannabis use in middle schoolers has statistically significantly increased from 2022 to 2024. So what changed? Legalization. So we do expect that we're going to be working with kids in order to make sure that they're not having access to substances that they shouldn't through the legalization process. But the mental health indicators are still a concern. We're going to keep working with student assistance. Colleen Judge is also in the room, so if you have questions regarding the actual program, she oversees all the student assistance counselors, and we can happily answer those pending time.
That's great. Thank you, Candace. Let's go to Linda, and then we'll stop for questions.
Sure.
Thank you.
Thank you. I can't be in the room without thanking the Attorney General for this funding. I came up to you about a couple of years ago and said thank you, because we're going to go to the next slide.
You have a great team. Thank you. Appreciate it.
All right, so this is a snapshot about the residential treatment. We have a call every Wednesday morning, as Ben said earlier. We take his heat maps, and we take the heat maps and we start looking about where the substances are, where people are non-fatal overdoses. And we have people on the call are individuals from detox, residentials, OTPs, our federal partners from HIDA. We have just about anyone who wants to join the call. It's a 30-minute call. We look at the numbers from the heat map and see what the overdoses are. We also refer to this wait list. This is a wait list that we've been tracking for a very long time about available beds that are for services and how that has changed. And the reason why I wanted to thank you is because before we have the settlement dollars, we started seeing our agencies close. We had Phoenix closed, we had Caritas closed. Eventually we've had Gateway Eastman House closed. And a lot of it had to do with 2 points. One was reimbursement rates from OHIC, which changed in October of 2025. And then a lot of it had to do with, we could not use our federal dollars to help with renovations. We couldn't use our federal dollars to just help assist with the agencies to more trauma-informed and agencies that were culturally linguistic appropriate services. We just couldn't use that funds. And all of a sudden, we have these settlement funds. I want you to know that we're stewarding them very well. We have a long-term plan, not a short-term plan, a long-term plan. The first thing that we needed to do was just to take a look at what we have, how long people are waiting in residential treatment or for detox, and how do we quickly make this change. We had to also build the capacity, and we also have to build the quality of treatment, because people were at a place where there were skeleton staff, right? And they're at a place where, you know, we needed to just help them with trainings, with workforce development as well. So this is the first slide. We go through this every Wednesday morning. This morning, this is 6/5 that I took a snapshot of this. At this point in time, we had 52 people on our waiting list, right? And then we looked at these snapshots across the board for the last 2 years and looked at, okay, is it more women that are waiting, more men that are waiting? What is the needs? What's the percentages? Where do we need to go, right? So next slide, please. As of this morning, just so you know, this morning we had our meeting, we're dropped down to 47 people that are waiting. But that also has to understand we've had a little heat wave. So when you have a little heat wave, people have a tendency to go into residential treatment. In a cold episode, you'll have people go into residential treatment. It's just the bear that we service. So our tier system was to build the capacity, and it had to be done step by step. So eventually we want to have people have treatment on demand. I want to stop for a second and just address the issue about pregnant women and what was brought up, and thank you for bringing that up. What we're talking about, particularly with pregnant women, because we have a women's program that you can go, and if you're pregnant and you can deliver and you can be there for 6 months and get reunification, and that's called Starbirth. What we don't have is detoxification services for pregnant women, because our detoxification services are called social detoxes. So they're not medically equipped to take care of complications that can happen. So you really need hospitalization. And Dr. Whiteman has been spearheading that effort to try to get an observation bed at Women and Infants Hospital for those who are pregnant women to be able to kind of get through the detox process. But we do, and are very successful for women who want to use methadone or buprenorphine through our opiate treatment programs. I just wanted to clarify that before I kind of moved on. So the tier system was to do a needs assessment. Where do we need to start? Where do we need to go? Okay, so here's where I'm here being transparent to you. This is mistakes that I've made right across the board. I got the money right off the get-go and got very excited and put out RFPs, but we hadn't gotten the reimbursement rate yet. And the skeletal system that we had was going, I can't invest into another facility. I can barely hold my own right now. So you'll see that there's a lot of RFPs that went out in 22, 23, 24, but there wasn't a lot of responses. Last time I was in front of the committee, I said, we can grow the system if we get new providers, but the providers we have right now are exhausted and barely holding their own. So they got the reimbursement rate in October of 24, and since then, we've been getting a great deal of responses to the RFPs. So just to kind of run you through, we have already invested, we have more men's beds. Galilee Mission opened up a 16-bed, Bridgemont expanded 5, AdCare had a fire. They were able to kind of fix the new building and get that up and running. Zinnia opened up another 14. So we've added over 50-something beds. Do we still have a waiting list? Yes. Why? Because some people just weren't calling because they couldn't even get a bed, right? So now we're getting there. Right now, I can say that we have a 16-bed all-male residential facility ready to go. I just can't tell you who it is. It's killing me. But I'm very, very excited. We put out 2 RFPs for just women, and I didn't get one response. Our plan is to do it again because now that the reimbursement rate's up, we're hoping. It's always the issue of finding a building, and not in my backyard. Who wants a residential facility in my backyard? So if you have a building, please let me know. Next. Limited children, we put that out. We had a couple of responses, but they didn't meet the necessity that you have when you have children inside a residential program. We might put that back out again. We have an adolescent program out right now. I have 2 vendors that are very interested, so we're in that process right now. It's an adolescent so we can keep maybe more kids in state instead of sending kids out of state. Thank you very much for the settlement dollars to be able to do that. The dollars pay for renovations of buildings, startup funds, furniture, insurance. These are things that our block grant won't pay for. So that's why it's so important to have these settlement dollars. Now we're at a stage where we're looking at our residential facilities that aren't expanding, just the residential facilities that have been holding their own. And we're helping them with improve the system and the quality that they have already. And that means we call it First Impressions Grant. And that grant is if you have a facility and you need to have something besides a metal chair in your admission office, maybe a couch and a chair, and culturally appropriate pictures and making people feel welcomed. That money, not a lot of money, but it's going to each residential facility as a grant to improve that first episode. That first impressions matter because retention is very, very important in treatment. We're doing contingency management. Average retention sometimes is only around 25%. Contingency management is bringing it up to 44%. So we're keeping people in treatment. Not one thing to get people in, but we have to keep them in treatment. Longer someone's in treatment, the more success rate. We have mobile health services, thanks to Kodak, we have 2 vans, but we're breeding all these fundings between our 3, thank you, Linda. We're breeding funding with our settlement with our block grants because that's the best way to utilize the funding source. So just to kind of, we're also, thank you, there was a program called Safe Landings, which was really wanted to get off the ground. It was a facility that you could go to in case you were administratively discharged or you just needed a triage center for substance abuse. And there's just facilities that we couldn't find a building to do that because they filled with high-risk individuals. What came out of that is we've expanded Recovery House to add partial hospitalization. So a person can go to treatment all day long and then go home to a recovery house instead of being in a residential period for a long period of time. So a lot of innovative things come with some of the money. What do we still need to do? More women and children's residential. We need to look at payment models for sustainable adolescent services. And of course, just continue with quality. And as you can see, we've braided a lot of funding. And we've also worked with other states. I steal from other states all the time. Candace and I sit on the National Association of Substance Use Directors. We are taking a program from the Boston Medical Center. It's called the START program. It's really effective with stimulant use disorders. And we're bringing it into the state. So that's it. If you have any questions, and thank you, Kathy. Thank you. Yes, Dr. Chen.
Thank you. Yeah, we have about 10 minutes for questions, actually. So go ahead, Dr. Chen, the floor is yours.
Wonderful. Thank you, Linda, and thank you, BHDDH in general, for all your good work here. A couple of questions about the treatment centers. Maybe you can go back to that slide, a few slides ago with the green and the status. There were a number of boxes that were open. You look at this and you think, well, we have a number of open beds. Just a general question for you or others. Our capacity for residential treatment, are we doing okay? Do we still need a lot more beds? And then the second question as we look at this is how does staffing affect this and/or insurance? So when we look at this, is it insurer dependent? And as we know, sometimes there's some barriers with insurance. What's the stats of capacity and access, I think, for your average Rhode Islander, would you say?
That's a great question. Did I plant you?
No.
So we have used a lot of the braided funding. So I'll say this publicly, and hopefully you can, if you have an action step from this meeting, you can take it out of this meeting. There's no reason for anyone not to go to detox or residential, regardless if they're insured, they're uninsured, or they're undocumented. So we found a way to pay. So there's no reason to go into treatment.
And what's the funding source?
We have several. We have stewardship, and we also use block grant. On some things we can't use on block grant. Some things we can't use on opiates. We can only use with alcohol. So it gets a little, but you find a way to braid 3 different funding sources. On here, availability, we really pay attention to more this line over here. So you'll see that we have facilities like residential meds. This is the Zinnia. They have 43 beds. They only had 3 waiting. The turnovers, you can pretty much get people into treatment. This is the biggest one right now, the Providence Center, men's and women's. They take a lot of people transitioning right out of the adult correctional institution. So they have a lot of people on the waiting list, right? So we have a reentry grant that we're trying to use that money from SAMHSA to kind of help with that reentry services as well. Does that make sense? You have other capacity? You want to know if we still need capacity?
Yeah, so if someone called today on a general day, do we always have beds open or is it going to fluctuate? Is there like a waiting list? How does that, what would you say capacity is in the state?
Well, I can tell you because I called this morning. We went through each one to see. The other thing I like about this is like if someone has open beds, MAP right now had 5 available open beds. This morning they had 14 for some reason. So what we did is we asked the other facilities, if somebody calls, please tell them MAP has an open bed. You don't have to go to the Providence Center. Your life is at risk. There's an open bed here. So there's more care coordination than there ever was before. Do we still need more? Yes. We need another women's and children's. We need probably another women's, but definitely the men's, which the men's is very close to being announced. But that's 16 more beds. I would suspect by our needs assessment, we need about 45. So we're not done yet, but we certainly look a lot better than what we did in 2022. So thank you.
Sorry, one more quick follow-up question, just on that. Are any of these LGBTQ specific and specifically like gender diverse or non-binary?
Zinnia has a separate room for trans. So if a digital doesn't feel comfortable in the men's unit or the women's unit, they have like a separate unit where they can decide which group that they choose to go to.
Dr. McAdoo?
Yeah, I was curious. Thank you again so much for this overview. I was curious if you could speak a bit to the availability and the type of treatment that's available for stimulant use disorder. I think you might have mentioned the START program, but I might have misheard.
Yeah, it's one of my favorite. We did a work group last year, just around this time with Dr. Chan. We brought the people in from the START program, Boston Medical Center and Cass Ave. And they were doing remarkable things with contingency management, which is an evidence-based practice. We have an RFP out right now. If anyone is interested, you can go to the PORI website, get more information about how you can mirror that program here in Rhode Island. And we have startup funds to do that, which I'm really excited about because there's document data that it works, stimulant use disorder.
Thank you.
Other questions for Linda or Candace? Yeah, Director.
Yeah, I just want to highlight one of the points that Candace made in her slide. It's a sleeping problem that we're going to be facing in the near future. It's the increased use of cannabis by adolescents, young adolescents, 12, 13, 14, 15 years old. It has a detrimental effect on the developing brain. It increases significantly the risk of first episode psychosis. It creates havoc in the learning environment, and some of those effects are not going to be seen immediately, although some are because of increased hospitalization, but they're going to be a cumulative effect in the very near future, and we'll be dealing with that. So it's probably not up to this group to solve that problem. We've got a few others, but it's a looming issue that we're going to be facing.
Dennis?
Dennis Baylor again. Thank you, Linda, and thank you, Candace. Candace, the last time I heard a presentation speaking about the services that are in the schools, junior high and high school, there was a gap in our urban areas, Providence primarily, and I had asked a question about racial data.
Yeah.
And at that, it's been a few years. At that time, it wasn't that good. You know, these programs tend to wind up in our suburbs where there's just many less children of color. Parents are more able to get other services. And of course, I know it's not your place to correct those, but do we know with the information that you have, if we've expended more into the urban areas and serving more children of color?
Yeah, and so Colleen can talk a little bit more about some of the specific areas that have come online, specifically with some of the settlement dollars. But with the COVID expansion, we got to near universal coverage of middle and high schools across Rhode Island. The ones that are not opting in are choosing not to opt in. So that's been very interesting. And we've had some schools that have been on the fence, not just because of money, but because of concerns about what is a student assistance counselor talking to my kids about. Been some issues there. So we're close to universal, and I can get you that data. We're actually working with student assistants right now on renovating their data systems. So we've had several meetings about what that's going to look like. In the future, we're going to be able to much better not only track a student through all the services that they receive as part of student assistance, but it's going to link to the school's data. So then we'll have all racial, ethnic, socioeconomic status, are they on free lunch? Like, we're going to have all this other data that we didn't have that connection to before. And it's because student assistance is going to operate it within each school. But do you want to talk a little bit about the expansion that happened in 2022, 2023?
Sure. We are in all of the Providence middle and high schools.
There's a few, so we're not in charter schools 100%.
We're not in the charter schools, but we are in the Providence schools. We're in the Woonsocket middle schools now. We're not in the Pawtucket schools. That's really the only urban district that we're not in. And the pushback from parents is coming from the suburban schools. And I don't know if Rachel wants to say anything, but we have partnered with the Mayor's Youth Prevention Team in Providence. We've also increased the diversity of our workforce. And so we are fortunate in Rhode Island to have, while we require a master's degree for counseling, I've visited other programs, our staff has visited other programs throughout the country, and we're fortunate to have some good pipelines, we need more. Diversity in our counselors, but we have increased the diversity of our counselors, we've been counselors, multilingual counselors. And we are in the urban schools much more than what you have seen in the past. And that's really been 5 years or so. Yeah.
It's been a big push. Really, it was like, let's get as universal as possible, but the ones that have opted out, we need to get folks on the school committees in order to fight that battle. I think that's kind of where we're at. And then we're going to keep using the settlement to just stay where we're at currently. And if it works out, I would love to expand. But right now, it's really been about, Rice did a great job. They secured a juvenile justice grant, and they also received congressional funding through Senator Reed's office. And so we're trying to spend on those resources first and keep the settlement for the sustainability over time, just because we don't know what we're facing in terms of federal funding cuts right now.
And to finish the answer to Dennis's question as well, we are doing, and I think Candace alluded to, we don't just do screening, brief intervention, referrals, but treatment. Sometimes we're referring students to where they need to be, which is youth leadership programs, youth development programs, and that's why I mentioned partnering with the Mayor's Youth Prevention Team, peer-to-peer, the Chris Collins Foundation, so that youth have the opportunity. They may be not your traditional leaders, kids who sometimes are on the edge or getting in trouble or don't see themselves as leaders, and we're really empowering them to have a voice in substance use prevention and mental health promotion and connectedness and feeling connected to their schools. So we're doing a lot more of that as well.
Sounds great, thank you.
We should move on to our last presentation, so we have time for public comment, and then we'll wrap up with next steps. So great questions, folks. The goal here was to give you information on where some of the needs are. So in July and August, as we make recommendations for fiscal year 2027, you have a good sense from people who are managing these contracts on where the gaps are in our state. So with that, I'll introduce Tamara Berman. She's an evaluator in the overdose prevention program at UHHS. Yeah, go ahead. And Tamara's going to talk about two programs that are managed.
So I just want, thank you. I want to lift up and acknowledge Building Futures organization, but specifically Michael Curtis, who is the program director here. So we've spoken, and if there's questions, I know he's online. But thank you to him and his team for laying out, if you go to the next slide. This is a new program that Building Futures is an organization that offers, it's a registered apprentice training program, but based on some data and alignment with the statewide strategic plan, specifically aligning with the prevention and recovery pillars. This program has really taken a multifaceted approach, and there's a number of things. They're really working to address stigma. They're doing a lot of outreach, awareness, and education. They are providing support, and they are developing their own recovery community and allies that are among the members of the Building Trades Council member unit. And so the different types of activities and programs that the team has been taking is doing outreach, education. They have marketing campaign that's really multifaceted, multi-tiered. They're doing lots of different ways in reaching their members. And from there, they are, Michael is working to connect folks with resources, and they're doing a lot of stigma training. Again, it's taking a bottom-up approach. So he's doing a lot of training and education with the apprentice program. He's also out in the field and is working on when he's getting connected with job sites and folks that are out working, but also a top-down approach and really working with leadership of the member unions. So he's taking a multi-pronged approach. Michael himself is a clinician, so within he's doing outreach and marketing, he's providing clinical support and referrals and to external sources. They're doing a number of special events and roundtables, like I mentioned, with leaders at work sites and through their apprenticeship program. Building Futures has a program, they call it Our Response, Our Recovery, but I want to ensure and lift up that they are also doing a multitude of different trainings that are around mental health and other prevention program. And a just newly launched piece of the program is a 24/7 care line that is providing emergency support, that is doing assessment referrals and then connecting to Building Futures staff to ensure that there is a continuum of care there. So you can hit the next slide. So just very broadly, we've been tracking, again, Michael's been ramping up and the team has been ramping up their outreach and the services that he's providing to folks. And so you can see here over time, over the past 2 years, the number of folks that he's been able to serve. So about 55 individuals that he's helped, but also engaged over time. So we're really tracking that, helping the folks that are in the construction industries. He's got his own, they have their own peer training, where he's trained 28 peers and 72 allies, again, amongst all the different industries and unions there. And then we just called out one particular training here. Like I mentioned, there's multiple trainings, but they've reached 148 individuals through their Our Response, Our Recovery training program. And part of that is that they're doing naloxone distribution. So you can see over time, the distribution there has gone up with the number of naloxone kits. And their website is one of the indicators that we really wanted to call out, which is that website. When I talked about the marketing and the outreach, that drives folks to their website where they can see the list of resources and access the different supports there that the members can take advantage of and utilize. So that is just a very broad overview of that program there and the great work that Michael and his team is doing statewide. And if you want to go to the next slide, I don't know if I will do it justice, but I'm going to first acknowledge Brandon and the Brown Pori team, Max, Jesse, Taylor, Todd. I know there's a bunch of folks that work on this team. That's who I could remember when I got here. So if everyone here is not visited, please do preventoverdoseri.org. And this falls under, it's aligned in the social determinants of health pillar. This, you can see here around the program description, is to increase and ensure transparency and access to data and resources. There's a number of dashboards, and every meeting around the task force you can access there. It's a website that has a tremendous amount of information for everyone to access. It's really the great entry point that can direct you to all the other sites. The team works very tirelessly on regularly really ensuring that they're using plain language, and using great clear data visualizations for diverse audiences there. So the team, like I said, they meet regularly. They're taking feedback daily, I know that, and updating it and ensuring community input into ensure that the information there on the website is really up to date, specific, and tailored to what the community needs and folks need to continue to build and track public awareness. There is a specific page here for the settlement where we've been, the team has been working to track and have access to dollar amounts and for a specific pillar. So you can access that prevent overdose or acronym for PORI. If you want to go to the next slide, if you're interested, they track. I mean, the team does a lot of tracking, but you can see here, Prevent Overdose RI receives, so they're getting about 15,000 active visitors a month. And so there's this year, in the past year, there's been 186,000 unique IP addresses. So you see that they're an active user means a unique IP internet address. These are a list of the top 10 websites that have been visited. This first one, the backslash, is just the homepage. So you can see there that obviously has been the most popular page, as well as fentanyl test strips and the page dedicated to preventing overdoses among youth. And then you can see here towards the right, when we're talking about different types of events, so there might be, the way that they are tracking it, the website activity is like if they're selecting buttons, we're tracking if folks are opening links or if they're downloading files. This is a website that's getting gets a lot of national traction too. So there might be folks coming from doing Google searches with looking for example, fentanyl test strips. So they might be click on there and that will bring it to that website. And then you see here, we've been tracking the amount of time in which people are visiting the websites, which would be an indication of whether if it was a marketing campaign where it's just a quick click and view, or if people are more engaged in ordering something or viewing more. So you can see there what the team is tracking. I don't know if I missed anything. Okay. Any questions? So yes, kudos to the team there for all the great work that everyone does. So those are our two programs.
Okay. So we've got a few minutes and then we'll open it up for public comment. Any questions from our committee members for Tamara? I actually have one. Tamara, would you mind just describing again why the focus on the construction industry?
Because it was, I mean, I know Rhino probably, okay. I know Rhino did, you can probably talk more about it, but I know there has been data and tracking through, is it what?
Yeah, or maybe.
Through suitors? Yes. That tracks and looks at the types of industries in which people have worked. And so this was the construction and building field trades was one of the top industries in which folks worked. Yeah. Yeah.
Other questions for Tamara? Perfect. Okay. I think we'll move it along to public comment then, and then I'll close with next steps for our July and August meetings, which will be very busy and where the votes will happen. So let's go ahead to move to public comment. We'll start with members of the public. Please try to keep your comments brief so we can get through everyone. We have about 10 or 15 minutes for public comment, and then we'll move to the Zoom. Are there any? Yeah. Hi, Linda. Nice to see you. The floor is yours.
My name is Linda Hurley, and I'm the president and CEO of ODAC. And thank you to everybody. These presentations was wonderful. Candace, Linda, everybody, thank you. And just a number of things. There was a question about, I think it was producer, about the decrease in in overdose death that's national. I've recently been on calls with NIH, the J-Coin project. I'm with those monthly. And it is their perception is, along with the ONDCP, that it's the remarkable proliferation of Narcan or naloxone. It's like, thank you, everybody, for that. And not just getting it out there, but also all the education that went to having first responders, you know, comfortable and sharing all of that. And they thought that was number one. And they thought that number two, and this was with the DEA and HIDIS and a few other groups, is that the product on the street right now is not as fatal as it was. The lethality is coming down because the entrepreneurs or the marketers that are selling this stuff don't want to kill their market. And they realized that's what they were doing. So I just thought that was an important piece to know, because that's the kind of thing that we need to be able to talk to the people that come to us for care in whatever, either harm reduction, recovery, treatment, wherever. And I also got that information from CSAT, the Office of Pharmacological Therapies. They track that for opioid treatment programs. So that was just pretty interesting. And then, sorry, I took notes. I'll be fast. I just have a question that Linda, you were talking about the first impressions dollars for residential.
Yes.
And I'm just asking, and I'm going to kind of combine this maybe, because also you were talking about brick and mortar efforts for residential treatment, first impressions for residential treatment, workforce, Kathy, workforce support for peer recovery support specialists. There is nothing in an RFP so far, and I'm really asking the committee to hear this. There's nothing, at least to our understanding, for established treatment providers, treatment programs. There's nothing in those there's no RFPs that allow for us to have first impressions, brick and mortar, workforce support. All these years, there's been nothing for opioid treatment programs. It's like, as people have talked to me, I think this is one of those athletic metaphors, but we've been, what is the term?
Boxed out.
Boxed out. And I know it's not intentional because we go after specific populations, but there are over 11,000 people in this state that are getting medicine for their opioid use disorder and need these services. And they need lovely buildings, and they need good plumbing, and they need spaces where they feel respected. And you know, we opened one and it was lovely, it's very lovely, but we have 6 others that are not. And so I'm asking, as you're making your recommendations for the RFPs to the different agencies, to just please pay attention to us, because, and anybody can find it, in terms of overdose death, the evidence speaks to treatment working the best for everything. It's very clear, and so I'm stronger about it than I've ever been. And the last thing is just a little one. The pregnancy and opioid use disorder piece, I'm thrilled that we're going to have more beds because we need them. I know that. For opioid use disorder, polysubstance disorder, residential facilities, particularly for detoxification, have never been optimal. And that's what the evidence shows. You can find it. It's safe because you want people safe, you want them to have a bed, and you want them to have food and clean and feel good, all of that. But that's what what they used to call the revolving door is all about, is people come in, they come out, they come in, they come out, as opposed to the longer term kind of care. So I'm happy to share any of this with any of you. I really am, because I know that there's diminished dollars. I heard that you're going to start to use them to continue some of the projects you've already started. that have not been sustainable yet and probably won't be because they can't bill. So the money's going to get less and less, and I'm just asking that you please pay attention to treatment, please, please. My neck even got red, I was worked up over this.
I appreciate your comments. Thank you, Linda. Yes, Sarah.
I guess it's more of just a comment, not a question. Doesn't really require a response, but I just wanted to raise a few things that I've been hearing from folks in the community, doing work on the ground, and just what we've all been witnessing with Talk Louder.
Yeah.
Sorry, I haven't had lunch, so I don't have a lot of
That's
energy. I also wrote my notes, so I'm not all over the place. But a few things that I think are relevant to this group, especially when moving forward with funding decisions in the future, especially given the current climate that we're in, and potential federal changes. Some of those federal changes have already trickled down to the local level and community organizations. The first thing I wanted to just make note of is the housing crisis that we have here in Rhode Island. Homelessness is a severe and persistent issue that continues to get worse in this state, with a 35% increase between 2023 and 2024. And a lot of the times, the systems are compensating for the failure of the lack of housing. So folks who are doing boots on the ground outreach, treatment facilities, hospitals, so on and so forth. A lot of people are expending their resources and money to kind of plug the gaps of the housing crisis, and it's not efficient. It doesn't sustain change. People are still unhoused. You just keep really, one of the people that I work with says bullet wound with a Band-Aid, and it's not working. It decreases people's likelihood of sustaining meaningful treatment. All around better health outcomes when people are housed. So if someone goes to treatment, they're back out on the streets, they're most likely not going to sustain treatment. They're not going to sustain a healthy life. And we're expending an incredible amount of resources on this and burning out workers that are already burnt out. So I just want to, I know no one here can fix that, but just keeping that in mind, like when we see this work being done, so many people are often compensating for multiple system failures at the same time to address already such a large issue. So it's, the weight of that is immense, and I can't underscore it enough. Also, with the federal changes, potentially lack of funding for incredibly crucial work like HIV prevention. We've all seen in the news how that's been incredibly targeted at the federal level. And currently in Rhode Island, as mentioned in one of the presentations, there are fewer than 5 diagnosed cases each year. I'm fearful that that metric might change once we lose funding that is used to support screening and prevention and treatment of HIV. So just wanted to keep that in the front of our mind. And with the funding changes, even if it's not directly, even if we're not directly seeing cuts to, let's say, like opioid prevention or overdose prevention, substance use, little or big funding cuts or funding changes in other parts of the system, again, lead to overcompensation in other parts where it causes cracks in all of the system, if that makes sense. So let's say the HIV program has lost its funding. Now, I don't know, SEN work has to fill in that gap and compensate. So now they're losing time, effort, and money there. So it creates all these holes that really just create a ripple effect and burnout to a field which we're already losing a lot of people in. So I just want to put those few things out there. The last thing I'll say is these settlement dollars have been incredibly helpful in sustaining this work and increasing the work and increasing staffing to conduct this work. We could always use more, I would say. And I also just wanted to highlight, since Linda, you had mentioned that naloxone is one of the key factors in reducing overdose deaths. I agree that has been one of the most crucial components, and the harm reduction workers in our state, I'm proud to say, hand out the most naloxone in the state, and it's obviously getting out to the people who are willing to use that naloxone and reverse overdoses. So great work. Literally, you're doing the most work. So
Thank you, Sarah.
Thank you, Sarah.
Let's go to, one more public member of the comment, then we can go back to the committee. Go ahead. If you can keep it brief, we're just at about 5 minutes.
Project my voice.
Yeah, thank you.
I'm Mia Peterka. I am the
Health Equity Zone Initiative Manager for RIDO. And I just wanted to respond to a question that was raised about funding. Thank you for that. I think what you're referring to is the HES-related legislation that was in the General Assembly this year, which, would have been wonderful if that passed. But I just wanted to assure everyone that HESs are not reliant on state appropriation. We've never received a state appropriation. We would certainly welcome that if that would happen. But in this current coming fiscal year, we are putting out almost $4 million in funding to HESs. That includes the code money, but it also includes funding from HUD, it includes Preventive Block Grant money, it includes money from the USDA, US Forestry, et cetera, et cetera. So there's a wide variety of funds available to HESs, and so we're pretty confident in the security going forward, but also we're continuing to look for other funds and propose public and private sources. So anyway, just wanted to fill that in, and if anyone has any questions, I'd be happy to answer.
Thank you.
Can I just say one thing, because we talked about naloxone, and I don't know if I missed it, but I want to remind everybody that in addition to the opioid settlement funds, the monetary funds that come, and you all decide on the percentage or the amounts across the pillars, we also do get 50,000 kits of Teva kits or Teva naloxone, and what that's doing is actually helping to save a lot of money to not have to buy the naloxone. And that was a direct result of the work and the work with the state, with the Attorney General's office, as well as listening to the community. A few years back, before the settlement money, when there was quite, concerns about not having enough naloxone. So I just want to remind everybody that that also is part of the settlement as well.
Okay, let's go to the committee members. We've got a few minutes and then we'll wrap up. Dr. Chan, the AG, and then Dr. McAdoo.
Yeah, so thank you, everyone. Thank you, Dr. Marshall. Just a couple comments. First, I want to just thank all my health department colleagues for presenting today. Margot, Jen, if you're on the phone, but really want to thank all the hard work from my health department colleagues. Second thing, I think I would be remiss if I didn't acknowledge on behalf of the Rhode Island Department of Health and Dr. Larkin, just all the work from the Attorney General in his office, from Addie, from the other staff. Not just on this, but really just defending all the other rights. I see your name in the news all the time, defending all the other restrictive policies that are going on. So I just want to thank you. And finally, I'll just say I'm really optimistic for this next year, especially with this 25% decline in fatal overdoses. I think a lot of that through the work of everyone here, and a lot of the community-based organizations. I do feel blessed to live in Rhode Island. I think despite all that's going on the federal level, it's nice to see us here acting as a group, state departments, agencies, community-based organizations, individuals. It's what keeps me going every day, especially. And I do really feel blessed to live in the state and safe, frankly. And I know that a lot of my patients feel that way as well. So thank you to the other state agencies. Thank you to Attorney General, and thank you to all the community members here as well.
Thanks, Dr. Chan. Thanks, Dr. Marshall. Good to see you. Yeah, I was really impressed with the presentation, so thank you. Thanks, Dr. Chan, for that. We'll continue to fight for the values that we have expressed here. You can just hear that our value system hasn't changed, and that's great, notwithstanding what's going on in Washington. Good news that you've probably heard elsewhere, but I wanted just to remind everybody that we have $30 million in coming in and due to a agreement of principle with Purdue and the Sackler family. So that's $30 million in real-time money. So that'll be coming in very, very soon. So glad the money's being spent so well, and grateful to the hard work that all the agencies are doing to make sure, and this committee.
Thank you for being here. Thank you. Do we have one more comment? Dennis?
I did have a question.
Yeah.
When I saw our Attorney General here, when I came to the door, so he's going to talk about the other settlement. So you answered the question that I was going to ask. I think there was $7 billion, I think, for the 50 states.
Nation, yeah.
For the states.
30 million here.
And my question was whether we're getting out of that, and what were the plans? And so you stole my question from me, but thank you. Thank you for the response.
You're welcome. Thank you.
That's great. And we'll be sure to bring more information about the Purdue settlement to the committee as soon as we have it and integrate it into our decision-making. We have a comment from Dr. Larkin, who's online, the director of the Department of Health. Dr. Larkin, are you there?
I am, so thank you. And I echo Phil's thoughts. Thank you, Phil, both regarding the work of the Attorney General in his office and also all of the staff at OHHS, Buddha, and Department of Health. But two quick things. In response to one of the previous comments, we actually did get our notice of award for prevention, HIV prevention at level funding this morning. So one, yeah, thank you. Yeah, well, I didn't do it, but thanks. So we'll hang by a hair for another year. The second, I think, is that we should have sustainability as a recurring agenda item at every one of these meetings and every one of the task force meetings. So I'm just going to propose that. I'll leave it to the chairs to decide if I guess I am the chair of the other one. So if Director Leclerc agrees with me, we'll do that on the ODOS task force, but we should also really do that in this meeting as well, because if we don't start talking about it, even if we don't get a solution, we certainly won't have anything after this settlement money runs out. So thanks.
Thanks, Director. Any last questions from the committee or online? Yeah.
I can just ask me afterwards. I was just looking for a list of all the HESs that receive the code funding, but I can chat with her.
Sure.
Send an email after.
We can get that for you. All right. Okay, let's go on to the next steps here. So thank you all. This has been a very informative meeting. In July, we will be shifting to talking about dollars. So we'll have updates for you on some of the spend from the prior fiscal, which ends June 30th. And as Director Larkin suggested, I would also like to offer that we start talking about sustainability of the funding and looking at that, what I call that decay function in the spending and how to manage that. And then I would like to also have a discussion about supplementation. That came up at the May meeting from Kristen Pendergrass from Shatterproof. And we will have for you a proposal for how to think about supplementation. We're looking right now at what other states are doing, and we'll bring that to the committee. Again, this is the idea of how and if it is allowable to use opioid settlement funds to replace particularly federal funding, which may be going away. So I would like to propose that we have that discussion in July. We'll also review the prior year recommendations from fiscal year 2026, and then have for you a straw person proposal for the recommendations which we need to vote on in August. So we'd like to get an idea, a concept of a plan in front of you in July, get your feedback, and then we do need to vote on the fiscal year 2027 recommendations, which are voted on in August, and then we'll go to the Secretary of Health and Human Service for approval. So that's the plan in July and August. We have a very busy few meetings. These are critical meetings. Apologies again that they occur during the summer, but please do attend. We'll make sure that we have quorum so that we can move forward with the committee's business. Kathy, did I miss anything before we close?
Sure. Amazing. Thank
Perfect.
you.
Okay, so the next meeting is in July. The information is on the slide. Can I get a motion to adjourn this afternoon? Thank you. Can I get a second? Dr. Chan? Any opposed? All in favor? Aye. Great. Thank you all. This closes the June meeting. Have a good summer.
Here it is.